Joint Institute in Chicago.
I'm Gjolaj, orthopedic spine surgeon from University of Miami.
Hi, I'm Sciubba. I'm from Baltimore, Maryland at Johns Hopkins University.
Hi, I'm Carrino. I'm the Vice Chairman of Radiology at the Hospital for Special Surgery in New York City.
Our topic today is radiation reduction techniques in spine surgery and spine interventions. There's many traditional and contemporary techniques that we've discussed, and our panelists here will chime in on their expertise. Starting with minimally invasive spine surgery and navigation as a way to reduce radiation exposure to the surgeon. Sciubba has extensive experience with minimally invasive surgery, and Dan, please give us your expertise regarding that topic and how it either reduces radiation or may expose the patient to more radiation.
Thanks, Joe. I think that this NEST meeting actually has been a great combination of two areas. One is robotics, navigation, because that addresses the ability to get screws in the right spots while minimizing radiation exposure. A lot of us use radiation to make surgery smaller, which we're all finding is helpful for the patient outcome, for complications. But the Achilles heel, if you will, of doing minimally invasive has been radiation. And so what's been nice is that this meeting, more than any other, and I mean this personally, is the advancement of robotics and other techniques such as navigation have really allowed us to take very complex surgeries and place screws where we want them to or make them smaller without the negative of the ionizing radiation.
Thank you, Dan. What about more traditional techniques, such as the freehand technique to place pedicle screws, for example? Mark, what's your experience with that, and what does the research show?
There's different ways to place pedicle screws, and people are getting very fancy with these navigation systems and intraoperative CT at the expense of high doses of radiation. Doing more traditional freehand technique decreases radiation both to the surgeon, the patient, and the entire staff, and it actually is a bigger question of radiation safety. In the OR, we've talked about wearing the proper lead vests, proper eye protection, increasing your distance from the fluoroscopy machine. But intraop, the freehand technique relies heavily on internal landmarks, so it's an open type of technique. It involves a high degree of tactile skill so that you place your screws properly. And then, of course, you want to limit the amount of fluoroscopy used, so you want to take high-yield images. A lot of studies have shown that when taking intraoperative images with a fluoroscope, you want to make it difficult so that it discourages you from taking multiple shots at once. And so a lot of studies have shown that taking AP images are high-yield type of images that can help guide your instrumentation placement. In addition, you want to use a hands-off technique. You don't want to be in the field when you're taking these x-rays. You either want to be behind a barrier or even leave the room while you get these high-yield images. It's not ideal for minimally invasive or percutaneous procedures. It's not a perfect technique for those types of things, but for the standard multi-level fusions in the lumbar and lower thoracic spine, it can be very helpful in decreasing radiation exposure.
Thanks, Mike. John, as a radiation specialist in interventional radiology, someone who does many spine interventions, what's your experience with radiation reduction techniques? What are your pearls, what you use in your own institution?
Yeah, I think it's really important to have a program where you work. So we have a program that's not only for radiologists, it's also for surgeons, also for pain management. It's really important to get the concepts across of what radiation safety are. There are some basic, simple principles, and to really effectively communicate them. I think you're going to see more and more institutions, as well as states and federal bodies, requiring people to get dedicated fluoroscopy training and competency. And it really provides an opportunity for education, not only for the operator, who's the person that is, let's say, working the equipment, but also to be cognizant who else is in the room. There's nurses, there's anesthesiologists, the patient. So I think the real key things are defining the program, getting the education out, and having some type of competency.
Thanks, John. I'd like to query my faculty here about radiation safety in regards to the patient. Do any of us really speak to the patient specifically about radiation, about their exposure to it during a big case, or is it something that we just include as part of our consent? part of doing business, so to speak. Dan, what is your opinion?
Yeah, thanks, Joe. I think that's a great question. I think that the very fact that this is really the first time I've really even thought about this question with our seminar means that it's going to be asked more often. We have something called informed consent, which unless you've been through surgery yourself, you never really know what surgery involves. So now we're trying to see in the future and say these are potential risks. And radiation has almost been, in my opinion, looked at as a business expense to the surgery, where this is something that you just have to accept, and it's part of doing business on that surgery. I think as we get better and as we get more thoughtful about the negative effects to the patient and to the surgeon, it's all going to trickle down into another level of risk that we're going to have to embrace and also calculate. So if one sits there and looks at a child undergoing CT scans, we are already very on top of being careful about children. When we start looking at older adults and a one-time shot here or there, maybe not so much, but if we're using multiple cycles of x-rays, especially as we do more minimally invasive and navigation, it's going to be an issue that is going to be brought up, and we're going to have to be able to have a working relationship with the patient to be able to give them the risks and what they mean.
Thanks, Dan. Mark, what's your experience with the topic?
Well, I educate the patients on what's going on in their surgery. So I do discuss on that whether I'm using a fluoroscope or if I'm going to use an intraoperative CT scan. But I do think that the topic's more pertinent to the providers themselves because the patient will have one surgery or two surgeries in their lifetime and only have that exposure. But the providers, the surgeons, the anesthesia staff, the nurses, the X-ray technologists, they all are exposed to these cases multiple times a day, multiple times a week. So I think the safety is actually should be targeted at protecting ourselves.
Makes sense. John, I'll ask you the same question, but I'll take it a step further. Regarding interventions, the difference between fluoroscopic guided versus CT guided. What's your experience with that, and how do you counsel the patient?
So we use the modality that we think is the best for doing a certain procedure. If a patient has questions, we may address their questions, but we don't bring it out in the informed consent process. I think what happens is that the patient trusts that we're using ALARA. So ALARA stands for as little as reasonably allowable, and I think that having that physician-patient relationship kind of trust us to use that principle, and I think that's really what is relied upon as opposed to when you're using radiation, let's say therapy or some other things. So I think it will become more and more of an issue where people may ask for their kind of cumulative doses, but right now I think it rests really with that physician-patient relationship.
Thank you. I just want to take it back to our own experiences as spine surgeons, Mark and myself and Dan. In your own practice, I know we've asked you to speak regarding freehand technique, but do you do freehand technique in your practice? Do you use some iteration of it or an image guidance? What do you do yourself?
That's a great question. The freehand technique itself is a very generic term, and in its most classical essence, it's using no imaging whatsoever to place your implants. And I don't do that. I use the modified technique where I take very limited imaging, fluoroscopy images in surgery, and that for most cases is very sufficient to safely accomplish what I'm trying to do. Some of the more complex or longer constructs or people that have had surgeries in the past that I need a little bit more detail, I do use an intraoperative CT scanner, but that's certainly not the norm for me.
Thanks, Mark. That's actually exactly what I do in my practice. Dan, how about you?
So my practice as of this day today is still largely dependent on the way I was trained, which is freehand technique. And what I mean by freehand technique, as it could be called many things, is take a spot shot once the patient with a regular X-ray machine, prone, get my alignment, expose, use external landmarks to cannulate every pedicle, place markers or screws, and then get another shot after those are done. So it's not completely without an X-ray, but it's not fluoro-based. That is different than when I do a minimally invasive case, which is dependent completely on fluoro. We are currently in the process at our center of getting CT, intraop CT, more available. And so if I were to have it available, I would use it more. And I liken it to navigation in your car, where I know how to drive home every night, but my navigation is always on, and it's always there as a backup if there's a detour. If I'm going to a new place, the navigation can be completely essential. So I think as we move into this, and things are made cheaper and made more available, even people who do freehand are going to have to find the best sweet spot for all of us between workflow, efficiency, cost, and safety. So I think that we're going to get more and more probably a navigation as time goes on to avoid the problems of the freehand, which is not perfect screws, and the problems of ionizing radiation with too many shots, and we'll see how that goes.
Thanks, Dan. And finally, John, in your own practice, are you relying primarily on fluoroscopy? Are you using any intraoperative CT for interventions? Are you using any ultrasound or MRI?
So those are all great questions because each of those modalities could potentially be beneficial. In the past we've used interventional MRI, but it is a big infrastructure cost. It's not readily available, so it's probably not ready for prime time. So I think focusing on the ionizing techniques but minimizing their use. So with the fluoroscopy systems now, you can create CT-like images, so-called cone beam CT or 3D X-ray, and those have become very popular with surgeons, and it's something that I use in some of the cases I do for spine injections to kind of combine the best of fluoroscopy and CT. And then other times we use a traditional CT approach. And ultrasound can be good for some superficial structures in the spine, but it really hasn't gained much traction beyond a couple superficial things like cervical facets or those other types of joints.
Thanks, John.